And, we've talked about, this morning we talked about the ABCDs of Medicare. I personally feel that if you don't have a good understanding of the entire Medicare program, it makes it a lot harder to work with your claims, because you don't completely understand how Medicare works. So we accomplished that. We talked about documentation requirements, and we talked about provider enrollment. Now we're going to get into sort of the meat and potatoes of the coding and billing for Medicare B and for Medicare Advantage plans, and they are slightly different. So let's go ahead and get started on that piece. Under the Medicare Chapter 15 of the Medicare Claims Processing Manual, the only 3 CPT codes currently that are covered by Medicare are the ones that are on your screen, on the screen right now, which are your chiropractic manipulative therapy codes 98940, 98941, and 98942. If you're listening to this and you're new to chiropractic, these codes represent spinal manipulation on anywhere from 1 to 2 regions of the spine, 3 to 4 regions of the spine, and 5 regions of the spine. Who can name the regions? Thoracic, lumbar, sacral, and pelvic. Cervical, thoracic, lumbar, sacral, pelvic. Those are your 5 spinal regions. And if you have subluxation present in 5 spinal regions and those subluxations are causing functional deficit to the patient, then you could bill out a 98942, a 5-region manipulation. Is it recommended? Not for ever, okay? Because as a patient's condition resolves and because some subluxations are probably going to be more significant than others, as these subluxations resolve with treatment, then you would start lowering your coding. You could theoretically start at a 98942 and then begin to lower your coding levels to even a 1 to 2 region as you continue to treat the patient and maybe just focus on the chief area of complaint. So you have 3 spinal manipulation codes that represent chiropractic manipulative therapy on anywhere from 1 to all 5 regions of the spine. Anybody an activator doc here? Okay, so activator doctors, oftentimes because as an activator doctor you are typically adjusting all 5 regions. I get that, but that doesn't mean that you can bill for all 5 regions. It's based on, because you're adjusting is a technique that adjusts all 5 regions to help treat a condition in maybe one chief region, you would still have to prove medical necessity for all 5 regions of the spine. It's not based on what you do or the technique you use, but based on whether you can prove medical necessity in 5 completely different regions of the spine. So what that means is it would be a much more rigorous exam. The treatment plan would have to include the treatment on all 5 regions and the reason for it. And so you just need to make sure that if you are a full spine adjuster, whether it's activator or whether you're doing diversified and your standard operating procedure is to adjust all the different regions of the spine, don't confuse that in your billing and coding, all right? It's not based on your technique, it's based on medical necessity and whether you can prove medical necessity for adjusting all of those regions. And if you can, go ahead. I mean, these codes are here for a reason, and there's no reason why you shouldn't bill a 5-region adjustment if medical necessity warrants that, all right? You're just going to have to prove it with your documentation. For Medicare, because the treatment of Medicare is limited to manual manipulation or manually assisted manipulation through some type of a device, to correct a subluxation, your primary diagnosis code should always be a subluxation code, which are, and a subluxation in the spinal area, not an extraspinal subluxation. So you have, these are the only codes that are permitted in box 21A of the CMS 1500 claim form. So is everybody familiar with the different boxes on a claim form? Yes? Yes.
I don't have them. No, I was raising my hand.
Oh, okay. Okay, yes, okay. So basically your CMS 1500 claim form, which is the standard claim form that is sent to Medicare and of course all the other payers as well, is made up of what they call 33 boxes. And in electronic format, these are called loops and segments. So the loop and segment replaces the box. But for learning purposes and for visual purposes, we always look at the paper version of the claim form to identify the box of the claim form in which there might be a problem or that needs specific attention. So box 21 is the box that on the CMS 1500 claim form in which you would record your diagnosis codes. Box 24 is the place on the claim form that you would record the CPT codes and refer to one of the diagnosis codes within box 21 as the primary diagnosis that would go against that spinal manipulation. Now, what a lot of providers don't realize, and unfortunately with chiropractic software, most software programs default to the first 4 diagnosis codes in box 21. So in other words, when you bill out a claim in box 24, you have a place where you can pinpoint up to 4 diagnosis codes from box 21 to that particular claim line. Most of the time they default to A, B, C, and D, the first 4. And so with Medicare though, Medicare claims processing is actually very specific, that they only want 1 diagnosis code pinpointed to box 24E, which is where the diagnosis codes get pinpointed on line 24. So you have to make sure that you're pinpointing a subluxation to box 24E from drawing that from box 21 on the claim form. These subluxation codes are normally not needed to be placed on a commercial claim, okay? These are very Medicare specific diagnosis codes, and actually I have seen it be detrimental in commercial billing to bill subluxation codes, because what the commercial payers say in some cases is that a subluxation is not a disease. A subluxation is not a condition, it is simply what it is. It's a misalignment of the spine. It's not giving you what that misalignment is causing, and that's what the commercial payers want to see. What Medicare wants to see is this, is basically a M99.0, 2, 3, 4, or 5 in the primary position of the diagnosis codes. For Medicare, we also have some Medicare Part B specific modifiers. And the Medicare Part B modifiers that may show up on a claim form would be the AT modifier. Now the AT stands for active treatment, and essentially this is for when the patient is under an active plan of care to treat either an acute subluxation or a chronic subluxation. You would use the AT modifier if you have the patient under a plan of care. And again, if you don't have the patient under a plan of care, then Medicare is going to assume that it is maintenance, and then that AT modifier should not be used in the case of a maintenance patient or a patient that is under supportive care. Another modifier that is used on our Medicare claims, and actually this is not, the AT modifier is actually very specific to chiropractic. I do not see, and we do billing for a lot of different medical specialties, right? But this AT modifier is not used on anything except chiropractic manipulation codes. And so this is a very, very specific code to Medicare Part B for chiropractic manipulation. The GA modifier, on the other hand, is a code that can be used by many different payers, okay? But it is a Medicare modifier, and for those of you who don't have a lot of coding background, basically, as billers and coders, we work out of 3 code books, okay? Who can name the 3 code books?
HCPCS, ICD-10, and CPT.
There you go. HCPCS, ICD-10, and CPT. The HCPCS code book and the CPT code book represent medical services, charges, procedures, diagnostic procedures, and so on and so forth. The HCPCS code book also it focuses on supplies, so you'll get all of your DME codes in your HCPCS code book. If you do injections, all of your injectables are found in the codes for the injectable medications are found in the HCPCS code book. So CPT refers basically to procedures. Then the HCPCS code book refers to supplies, drugs, and so on and so forth. The HCPCS code book has been developed by Medicare. The CPT code book is developed and maintained by the AMA, okay? So the general rule of thumb in billing and coding for Medicare is if there is a Medicare code or a Medicare modifier, you use the code out of the HCPCS code book. For those of you who bill eSTEM, all right, you know we have 2 codes for eSTEM, right? What are the 2 codes for eSTEM? 97014 and G0283. Both of those codes are eSTEM codes, but the G0283 is found in the HCPCS code book, and the 97014 is found in the CPT code book. So the Medicare rule is if there is a Medicare code for it, you use the code out of the Medicare code book for Medicare patients, which is why if you go to the physician fee schedule for Medicare and you look up 97014, it's not even there. But if you look at G0283, it will give you pricing for G0283. Now your commercial payers have the option to choose either one. So United Healthcare, for example, right, requires you to use the G0283 code, and they don't recognize the 97014. So if you ever bill eSTEM 97014 to United Healthcare, it actually gets denied as experimental and investigational. But if you rebill it with the G0283, you'll get paid because that's their code of choice. For Medicare, it's always, the rule of thumb is always, if it's in the Medicare code book and it has an equivalent code in CPT and it's a Medicare patient, you always defer to the Medicare code. Yes?
So I've seen it where Medicare still is going to process the 97014.
They don't, I mean, but you don't get it.
Not really processed, it's still going to be denied to the patient is not covered, but I don't see like the experimental denial.
No, not in Medicare, but in the commercial payers you will.
for United
Yes,
Healthcare,
yes,
So when we're billing Advantage plans, we should use the G code?
yes, yes. So you stole my thunder, Doc. I mean, seriously. No, but that's great because that's exactly what I'm talking about. Because under the Medicare Advantage plans, let's say the patient has expanded coverage and they do cover therapies. So you've got to bill that G code, not the 97014 code, because again, this is a Medicare contract for the Medicare Advantage, so you want to use that G code instead, all right? And by the way, I am just going to say that G code actually reimburses traditionally higher than the 97014, and it's not the payers usually don't have a problem with you billing the G code. You'll get the 97014 denied, but I've never seen denials on the G codes. I don't know if any of you have, but I've never seen them deny that G0283 when it's billed to a commercial payer, and the reimbursements are actually a little bit higher. So, so anyway, the AT modifier is a Medicare-specific modifier. The GA modifier, coming back to this, is a modifier that lets the Medicare know what? What does the GA modifier let Medicare know? That what? That it's maintenance. What else? There's an ABN been signed. Suzette's answer is correct. It doesn't mean that the patient is a maintenance patient. It means you have a signed ABN form on file, and the patient chose option 1 on the ABN form, okay? Which option 1 is continue to bill Medicare, all right? So you continue to bill Medicare, but you notify them that you've had the patient sign an ABN form and there is one on file. So it is an informational modifier that lets Medicare know that they're no longer under active treatment and that they've signed an ABN. And it is a misnomer. That's what I hear all the time, is that, oh, it's a maintenance modifier. No, it's not. It's a modifier to let Medicare know that a patient has made an election to continue to bill maintenance, to continue to bill Medicare even though it's maintenance. So I know it's like tomato, tomato, but that modifier means the same if, for example, you know, we work with medically integrated practices, and sometimes a patient needs a knee brace, okay? And just for those of you, if you've never billed for braces, there's something called a regular use of life of a brace, which is for Medicare 3 years on a knee brace. So if the patient had a knee brace 2 years ago and they don't have it anymore, it doesn't fit, they need a new one, okay? We have to tell that patient, well, it hasn't been 3 years since your last brace was dispensed, so we will bill it out, but if Medicare denies it because it hasn't been 3 years, you'll be financially responsible for that brace. What do you want to do? And we give them exactly the same ABN form that you give them for spinal manipulation. So that ABN form is not just for, you know, chiropractors. It is used in surgical procedures. It's used in DME. It's used in a number of different applications, and so it means that an ABN is on file and the patient has chosen option 1 on the ABN. The GY modifier is a very important modifier, and by the way, all of these modifiers that you see here, you will not find in the CPT codebook. You'll find them in the Medicare codebook, in the HCPC codebook under the HCPC modifiers. And so the GY modifier is used in case you need to bill Medicare for non-covered services, which we'll talk about that because you're not required to do that, but sometimes a patient needs you to bill that non-covered service so that they can get a proper determination on the secondary plan. In some cases, the patient may have what we call a true secondary, like a retirement policy or something, where they actually have expanded coverage over and beyond the spinal manipulations. It's not a huge percentage of patients, but if you do have a patient that has that type of a plan, then you've got to bill the non-covered charge to Medicare first so you can get the proper denial, and then bill it to the secondary, okay? And you do that with the GY modifier. If you bill a non-covered charge without a GY modifier, it gets denied as a contractual obligation, and that you would have to write off or do a corrected claim on to get the proper denial, because the denial has to come in as what they call a PR denial, patient responsibility. Okay, and to do that, you use the GY modifier. The GP modifier is appended to physical therapy codes that start with 9-7 or physical therapy codes in the HCPC codebook like G0283 to indicate that the patient is under a physical therapy plan of care. Again, this is another one that's a little bit misunderstood, because I'll hear people say that the GP modifier means that you're telling Medicare or you're telling the payer that the procedure was performed by a physical therapist, and that's not what that means. It means that the patient is under a physical therapy plan of care. A chiropractor can write a physical therapy plan of care. It's within your scope. So when you're billing the 97 codes and you're billing the G0283 codes, you should be appending the GP modifier, and you should actually be using the GP modifier now for all payers across the board, okay? Because this was something that over the last couple of years has gradually changed, and all payers are now requiring that GP modifier on your therapy code. So if you're getting denials on therapies for an improper modifier or missing modifier, it's probably that one, okay? Now we can talk about multiple modifiers and all of that, but that one's a real important one. And again, these modifiers are found in the CPT, I'm sorry, in the HCPCS code book. All right, so what we're going to do is we're going to look at the Palmetto GBA LCA, which we determined prior to lunch was a local coverage article that's published by your Medicare administrative contractor, which in this case is Palmetto. And we're going to look at some of the excerpts that instruct you on how to properly bill your Medicare claims to Medicare Part B. And then we're going to address Medicare Advantage billing. So for Medicare purposes, it states, and again, I did basically screenshots of the actual LCA, so it's not my words, it's theirs. The chiropractor must, and they actually have that in bold, place an AT modifier on a claim when providing active corrective treatment to treat acute or chronic subluxation. They actually state it right there. Okay, so if you ever get pushback from Medicare saying, oh no, we don't cover chronic, you absolutely have a fight on your hands, okay? Because they do cover chronic subluxation if you document it and bill it correctly. However, the presence of the AT modifier may not in all instances indicate that the service is reasonable and necessary. As always, contractors, which is Palmetto is the contractor, may deny, if appropriate, after medical review. So they have the ability and they have the right to review your claim, and they have a right to review the spinal manipulation codes you bill with AT to see if it is actually active corrective treatment, or does your documentation seem to point in the direction that this is now a maintenance patient, and you know, you have to know the difference. So sometimes what happens is the AT modifier, or actually it's not sometimes, it's kind of quite a bit, the AT modifier is overused, all right? And Medicare continues to get billed for services that are clearly based on documentation and the patient themselves, supportive versus corrective in nature. So why do we do that? Are we a bunch of frauds and crooks? No, we're not. But we want to help our patients. That's what I hear. Oh, I just want to help the patient. And I want the patient to make sure they can use their insurance, okay? I hear what you're saying. It's all about the patient, right? I had a doctor tell me just the other day, I was talking to him on the phone, he said, I put my patients first and compliance second. I was like, okay, but, you know, where are your patients going to be, buddy, if you're in jail, right? I mean, you're not, you know, if you're saying I put my patients first because, you know, I'm going to continue billing so that I can get the most out of their insurance so that they can get paid and they don't have to pay out of their pocket. I totally get it. You know, it's a lot of money for some patients, right? But at the same time, don't tell me you're putting your patients first and compliance is down the road. All right, because that's really not putting the patients first. Because if you go out of business because you put the patients first and now you've been so heavily fined that you can't keep your doors open, I mean, where is the logic in that? That's all I have to say about that. But make sure that you do not use an AT modifier on a Medicare claim when the documentation clearly does not support active or corrective treatment. Under the coding information, under the LCA, it gives your 3 spinal manipulation codes, 98940, 1 and 2. 98943 is not even on the Medicare fee schedule. So if you try to look up 98943 on the Medicare physician fee schedule, there's no pricing information on it. So it is clearly not a covered service. And do any of you bill 98943 with a GY modifier to Medicare?
I have one where she does, but that's the only way she's able to get a PR denial. If she doesn't, she's Palmetto.
Mhm.
If she doesn't bill it with the GY, then it's a contractual.
Right, right. So some MACs will reject the claim outright if a 98943 is on the claim. Now Palmetto, it's nice to hear that you can actually put the 98943 on the claim to try to get get the secondary, a true secondary maybe to pay for it. But some of the MACs, like Wisconsin Physician Services, NGS, and I believe Noridian, if you put a 98943 code on a Medicare claim, they'll reject the whole claim, and you have to remove that code and then send it back in. They'll say that this is not recognized by this payer. So these are the only codes based on the LCA that should be on the claim form with an AT modifier. The modifier that they tell you to use is AT, acute treatment. This modifier should be used when reporting these 3 service codes. And then these are the only diagnosis codes on the LCA. So there's a lot of philosophy, let's say, around diagnosis coding for chiropractors. Over the years, there's been where you're supposed to, when you do your diagnosis codes, you should put a subluxation and then an associated condition, followed by a subluxation and an associated condition. There are certain payers that if you point a diagnosis code on your claim line, line 24, that is not one of these codes, it will deny the claim. So if you let's say you do an M99.03, which is a lumbar subluxation, let's say it's an L5 subluxation, okay? And then your next code is low back pain, M54.50, and you point that low back pain on line 24, some MACs will deny the claim, saying that that is not a valid diagnosis code per the LCA. That's why the LCA is so important. My recommendation is, and I know that you may want to justify more treatment on a patient, and I totally get that, but Medicare, the way the automated claims processing goes now, is they're not even looking at the diagnosis codes that you have in box 21. All they look at is what is pointed, what is the diagnosis code pointed in box 24E. It should be one diagnosis and it should be a subluxation code. So it technically should not even be ABCD. Now, some MACs overlook it and they go ahead and pay it, but some MACs are getting very, very strict about that and they don't. And eventually, because of the Medicare rules for what is covered and what is not covered under the LCA, as the editing process of these claims gets more and more sophisticated, you may start to see denials if you have non-subluxation diagnosis codes pointed to claim line 24. All right, so that's, I don't know if Palmetto is paying on claims that have non-subluxation codes.
You need subluxation as the first one.
Yes, but even like ABCD, if B is low back pain and you do ABCD, I think Palmetto is still paying those. Yeah.
Yeah, so I joined another practice as an independent contractor. I came from Maryland, so this is all, I took the advice of the other doctor of how to do this.
Uh-huh.
So I had only done it like that.
Yes.
And she instructed me, whatever the primary complaint, you put that, if it's low back pain, O3, then you need,
Mm-hmm.
the,
Yes.
you need
Yes.
that other diagnosis.
And you know, in your problem list, like in your documentation in your EMR, I think that's a good strategy. But for billing purposes, if you're getting paid, you're getting paid. But beware, because every year, January, the new, what they call stupid smart edits, I call them stupid smart edits, come out. And if a smart edit comes out that recognizes a non-subluxation diagnosis in your diagnosis code pointer, it could start denying your claims. So if you get, let's just say, if you start seeing medical necessity denials on your AT claims, look at how you're pointing those diagnosis codes. And if you have diagnosis codes in the pointer box, box 24E, that are not subluxation codes, that could be the culprit, all right? So just FYI, right now, I think with Palmetto, we're okay. Anybody bill Novitas? Okay, are you having any issues with that?
I would say in the last 2 months, it seems like there's just a lot more denials, but, you know, every now and then we do have the codes in the wrong position, but I feel like it's heading that way.
Yeah.
And my question
This is why I'm saying it, because it may not be happening right now with Palmetto, but I do know it's happening in other Macs, and so, you know, things begin to get standardized over, you know, a period of time. So just kind of giving you forewarning on that if you start to see the increase in those denials, yeah.
So back up in box 21, where it's got, I guess they call the diagnosis codes, like years before we've been taught to fight for more coverage in Medicare, that you would want to put down like everything that was being done, and it would have a code that it wasn't covered, you know, for. Should we not do that?
No, box 21, you can put 12 diagnosis codes in there, and that's perfectly fine. But what Medicare is reading, or what the payer is reading, is of those 12 diagnosis codes, what are we treating the patient for today in box 24E? The subluxation.
So even if there's multiple subluxation codes, like just put down one.
Just A.
Just a,
It should be A.
And then what happens if there is other non-covered services, say, like kind of your GYs there? Should those not have any pointers at all? Should those be left open, like no pointers?
Well, you have to put a pointer. So you're going to have to point a non-subluxation code to the non-covered services, like physical therapy. You know, maybe you're doing, you know, manual trigger point therapy to break up a muscle spasm. So then you're going to use the M68.830 or I can't remember which one it is, but it's a, you know, it's basically a spinal, you know, muscle contracture code. So yeah, but that would be only on your non-covered services.
Okay, so that's still safe to do the document?
Yes, absolutely.
So just, we should, with note of this as well as Palmetto, because I've got one office in either location. So that's where it's kind of starting to get really complicated.
Yes.
Because one does one, if you see one patient in one location, and they cross the county lines close, they cross over.
Yeah, it can be tricky. So standardize it. You know, do what you know Medicare is going to approve, right? And then, you know, leave the rest of it off. But just think about this. You know, think about box 21, where 12 diagnosis codes can be placed in box 21. That's the equivalent of the provider's problem list. Okay. Think about this in terms of internal medicine, for example. An internal medicine doctor treats patients for a myriad of conditions. You know, they may be monitoring a patient's high blood pressure. Maybe the patient has type 2 diabetes with macular degeneration, obesity, and other kind of chronic conditions that they have problems with. That becomes the internal medicine doctor's problem list, okay, of all the different conditions that this provider is managing, okay? That's what goes in box 21, the problem list. Box 24E represents the problem from the problem list that they're treating today, all right? So when the internal medicine patient comes in to the internal medicine doctor, they say, all right, what are we here for today? Okay, well, I need to get my evaluation and get my labs done for my type 2 diabetes. So that's going to be the primary diagnosis that's pointed from the problem list in box 21 to box 24E. For chiropractors and Medicare, all right, Medicare Part B, this comes from your problem list and is the primary diagnosis to be pointed to box 24E if it's a Medicare B patient under active treatment. Yes?
Just for clarification, the first 4 in the list of possibly up to 12 should be that, to make sure one of those is what fits.
Yeah, I mean, like I said, the Medicare claims processing system only reads the first diagnosis code. Even if you put 4 on there, they're not reading 4, they're reading A. What is in position A? Only those codes if you're Palmetto. Okay? Now, if you're Novitas, you actually have more diagnosis codes, and I'll show those to you in a sec. Yeah.
My question is, if they're only looking at the 120, how do they know if it's 1 to 2 or 3 to 4 levels?
They don't. They don't.
Okay, I guess that's why I always thought we had to.
Yeah. They don't. They're you know, it's kind of like the IRS, right? You basically, you know, you submit a tax return to the IRS. You say, all right, I made this much money, and this is how much goes into the bank, and these are my deductions, right? And you can tell the IRS anything, and they'll process it, and every once in a while they're going to say, prove it. So that's when those diagnosis codes come in place. Prove that you could justify a 98943, and then they're going to look at your problem list, and then they're going to, but they don't look at that when they're processing the claims. It's not how it works, okay? So
So is it across the board, like at the Cigna whatever, or is it just Medicare?
most payers only read pointer A, because pointer A has to relate to the chief complaint. So what is the chief complaint that you've seen the patient for that day? Okay, and again, 21 is your problem list, okay? So yeah, they care about the chief complaint in box 24E. They care about the rest in box 21. Okay, and then what's going to happen is in an audit, they're going to look at what you billed, they're going to look at the problem list in box 21, and then they're going to look at your documentation to see if your documentation supports that you applied the other diagnosis codes to the, to the condition being treated, so that you could justify a 98943, and that's a 98941. That's why 98942 is so heavily audited, right? Because you can only point one diagnosis code, and then you and you're adjusting or you're stating that you have 5 regions of the spine that have medically necessary criteria to adjust. Now they're going to want to look at that, right? They don't usually fuss with the 98941 so much. I mean, have any of you even gotten audited for 98940 versus 98941? We hardly ever see that anymore, really. It's mainly a frequency, not a code level. Now, if you're audited, they may look at the code level that you build and determine that you didn't give enough diagnosis codes to justify in your problem list a 98941, right? But when it comes to the claim itself and the pointer, just the one is necessary, okay? Great questions, guys. Yeah?
With the box 21 problem list, it used to be with Notivis that basically the odd ones had to be a spinal diagnosis. Is that no longer the case?
I'm sorry, say that again?
It used to be with Notivis that you say basically position 1, 3, 5
Mhm.
always be a spinal code. I think it was
That's an old LCD, and actually it was a wonderful LCD because it gave you in secondary diagnosis codes. Those are all gone. Those lists, and I don't know if you remember that, Novitas had a fabulous LCD where it stated for Medicare, here are your primary diagnosis codes, and then it gave us a list of diagnosis codes that warrant short-term treatment, medium-term treatment, and long-term treatment. And your short-term treatment, you know, Novitas actually said 6 to 12 visits. I mean, they were very specific in their LCD, but that is all gone away several years back. First of all, they removed all the coding information out of the LCD and created the LCAs, which are your billing and coding articles. And they actually did that to standardize billing and coding across all MACs, because you'll see that the LCAs are almost identical in all the MACs now. There is not that same where Novitas had, you know, 1 million different diagnosis codes and Noridian only had 5. Now, this is what you're seeing, right? You're seeing this, or the Novitas LCD still gives you a few more, okay? And so this actually comes out of the Novitas LCA, the Group 1 codes, and it's 12 codes, and it is the segmental and somatic dysfunction codes M99.01 through 05, and then you have these subluxation complexes, vertebral, of head, cervical, thoracic, lumbar, sacral, and pelvic. So you've got, I think it's 1, 2, 3, 4, 5, 6 more that you can choose from. These are actually decent diagnosis codes to use when you have multiple subluxations in one region. Okay, so if you have subluxations at C6, C7, you could use, and you bill not Palmetto, because it's not on the Palmetto list, but it's on the Novitas list, and you could bill, code M99.11 to help the payer understand that you're looking at multiple levels of subluxation within the same region. Okay? Yes?
Question about those lists that I know they're not useful, can't be used now, but would that be useful as a guide for me to kind of know when the patient should be switched from AT?
Yes, very good. And as a matter of fact, I just noticed in May at the spring conference, the UVCA spring conference, Dr. Mario Fucinari is going to be teaching documentation compliance. And he actually has a book that he wrote, and I think this is like his 10th year that he's done this, and it's called the Top 100 Diagnosis Codes for the Chiropractic Profession. And he still has those codes in that book listed by short, medium, and long-term treatment. And actually, it's still a very, very good guidance that you can use to help you understand, you know, when it would be appropriate based on the patient's presentation, when it would be appropriate to move a patient into maintenance care, but it can't be used anymore for Medicare, but that list is still in that book. And so if you go to doc@askmario.com and send him an email and say, Lisa told me to get your book, I think he'll give you and Lisa said to give you a discount. He'll yell at me, but that's okay. He's actually teaching on my cruise, on our Gold Star cruise that we're doing in February. So anyway, yeah, those lists are still around, and they're still good guidance, you know, used for guidance, but not for claims. Yeah. Yes.
For the non-covered Medicare codes, should they also only have 1 pointer?
Yeah.
Okay, so you just really keep everything as 1 pointer.
1 pointer.
Okay.
Mm-hmm. Yeah. You know, and it may be difficult to do. This is not easier said than done, because most of the software programs default to ABCD, which means you would have to literally change the way you'd have to point every single time, which I know can get very cumbersome. So, you know, my feeling is if ABCD is not creating a claim denial, leave it. You know, don't give yourself and your staff extra work, you know, by feeling like you have to remove B, C, and D and only point one diagnosis code. But I am just saying that for Medicare, the MACs are going to be moving towards the edit where if you do have more than one, they may deny your claim. okay? Just keep an eye out for that, okay? So, billing for, do we have any more questions? I don't want to, this is really good stuff, so.
What was the email again for Doc?
doc@askmario.com, okay? And his website is askmario.com. And he has that book, you know, plus a bunch of great compliance books and things like that. Mario and I are great colleagues. We do a lot of co-teaching together. We actually taught a Medicare and documentation session in Wisconsin this fall together. And so he has he is a chiropractor, so he looks at it from the clinical side of things. So for those of you who are doctors, he's a wonderful resource to have to help you with your documentation compliance, okay? And if you're concerned about documentation compliance, I would say make sure you register for the spring conference, because he'll give you some great instruction, okay? Yeah?
I just wanted to clarify on what you said for that. You said that Medicare is moving to that edit of if you have multiple pointers to that CPT, it could trigger a denial.
Mm-hmm.
Okay, so then kind of just be preemptive.
Yeah, be preemptive, or just be aware. You know, I'm not saying change what you do right now. If it's not broke, don't fix it, right? But if all of a sudden, come January, hint hint, you start getting denials for medical necessity because you used an unauthorized diagnosis code in box 24E, that's probably what is happening. They're reading all 4 diagnosis codes and they're seeing that 2 of the 4 or 3 of the 4 are not on the LCA, okay? And that's why you may be getting that denial. So I'm just kind of giving you a little bit of forewarning based on, as a billing company, we bill in 46 states and we bill all MACs. So we are starting to see this happening with other MACs, not yet with Palmetto. And maybe a little bit, like you said, a little bit it's already happening with Novitas, but, it could happen. I'm just saying, All right, any other questions about this? About code pointing? Okay, great. So, do you have to bill Medicare for non-covered services? No, you don't. If the patient asks you to, do you have to bill Medicare for non-covered services? Yes. If the patient asks you to, you have to bill Medicare for non-covered services, all right? So make sure you don't tell a patient, well, I went to a seminar and they said I don't have to bill for non-covered services. If the patient asks, they have a right to have their insurance billed for whatever they want, okay? But what you have to tell them is this is non-covered by Medicare. Now, if we have maybe you're asking for it to be billed because you have a supplemental or a secondary payer that you think might cover it, and that's usually the Medicare patients like, well, I have a secondary, so I want my non-covered services to be billed, so my secondary will pick it up. And we'll talk about this when we talk about coordination of benefits, the difference between a Medigap plan and a true secondary plan, very, very different. True secondaries may actually cover those therapy services, but a Medigap plan won't, all right? Because a Medigap plan only gaps coverage that Medicare approves of. So if Medicare doesn't approve of it, the Medigap is not going to approve as well. So patients may ask you to file the claim. The patient may have a true secondary, or Medicare may be the secondary payer, all right, in some cases. So if Medicare is the secondary payer, the primary may cover those therapy codes. And so there are instances in which you would want to bill for those non-covered services, but you are not mandated to do so. All right. And if you bill the non-covered services, you have to make sure you append with a GY modifier. GY means statutorily non-covered. It means in the contract it is not covered by Medicare. Medicare then recognizes that, and then they deny it to patient responsibility. So then you can do whatever other administration you need to do. But you know, if the patient is being very stubborn and they're like, no, my secondary is going to pay for it, then bill it with the GY modifier, get the proper denial, get a credit card on file from that patient, so that when it does get denied, you can bill their credit card and let them know that that's what you're going to do. You're not going to balance bill them for these non-covered services because you know, but you tell them, all right, we'll do it, but here's what we know and here's the way it normally happens. And so we're going to bill it for you because you want us to, but if Medicare denies it and your supplemental denies it, then you're going to be financially responsible. Are you good with that, you know? And depending on the patient, you may want to get it in writing. If if you're thinking that the patient is just trying to get over not, paying you for anything. All right. Anything else we need to cover on the non-covered services? I mean, it's pretty, for Medicare Part B, it's pretty simple. You don't have to bill for the non-covered services. And if you do, you bill it with a GY modifier. Medicare Advantage billing is going to be a little different, guys. First of all, you're going to need to understand your contracts with the Medicare Advantage plans in order to bill and correctly counsel your Medicare Advantage patients on what is going to be covered and what is not going to be covered. For your Medicare Advantage plans, if it's a plan that you are not familiar with, always verify coverage. And the patient's insurance cards let you know what type of Medicare Advantage plan you have. So you could, maybe, I think most practices would say that usually they're going to see very commonly maybe, a handful of Medicare Advantage plans, different Medicare Advantage plans. Once you verified the coverage for Humana Gold PPO Plus, it's going to be the same for every patient, right? You don't have to verify every single time, but if you don't know the terms of that particular Medicare Advantage plan, you want to do a very thorough verification of benefits. And your verification of benefits should go something like this, all right? Number one is this plan a direct Medicare guideline plan, or do you have expanded coverage beyond the Medicare guidelines? Okay. Is this plan directly based on Medicare guidelines, or do you have expanded coverage beyond the Medicare guidelines? All right, and if they don't know what you're talking about, then give them a scenario. You say, because these customer service reps in India and Pakistan do not know what you're talking about, right? They're going to say, oh, we follow Medicare guidelines, right? They have no idea what that means. So what you tell them is, we are a chiropractic office. Under Medicare, Medicare only covers spinal manipulation, these 3 codes. I'm asking you, does your plan cover 97110 when it is rendered by a doctor of chiropractic? Is there expanded coverage? All right? And then they have to go and check, and then they'll tell you yes or no, that they have the expanded coverage or no. In some Medicare Advantage plans, they may cover your exams, all right? They may cover the therapies, the x-rays. So you will always want to verify coverage on your Medicare Advantage plans. If you're out of network with the plan, all right, and when you reach out to the plan administrator, they state that there are no out-of-network benefits, even if they're wrong, notify the patient. Tell them you'll bill it, right? And see what the Medicare Advantage plan does. But notify the patient in advance, get their signature that you notify them that you are out of network with the plan, and that their Medicare Advantage plan may not have any coverage. Now, with Medicare Advantage plans, the only time being in or out of network matters, all right, is if it's a pure HMO plan. So if it is one of the basic Medicare Advantage HMO plans, they're going to be very restrictive on what providers the patient can see, all right? But they still have to follow Medicare guidelines. So if you're a provider with the plan, all right, under the HMO plan, and if in network, and if you agree to the plan's terms, like let's say, for example, the plan requires in-network providers to get prior authorization, then you have to follow those rules. But if you are out of network with that plan, it may be reduced benefits, it may be no benefits. So you need to find out for sure how those plans behave. Remember that your Medicare Advantage plans must follow Medicare guidelines at the very minimum. What does that mean? It means that they must cover those 3 spinal manipulation codes, okay? They actually, unless it's an HMO plan where prior auth is written into the plan, they must not require you to prior auth the plan, okay, and to prior auth the services. So if you're not in network with that plan, you do not have to get prior auth for that plan, okay? Now it may not, if it's a pure HMO plan, they may not cover it because you're not an HMO provider, but under the Medicare Advantage PPO plans, it doesn't matter if you're in or out of network, they have to follow Medicare guidelines, which is why a lot of times you will call a Medicare Advantage PPO plan and they'll say, oh no, we don't see you as a network, but when you process the claim, you get in-network payment, because it doesn't matter, because they have to follow Medicare guidelines.
If you're Medicare participating.
Yes, you have to be a PAR provider with Medicare, but you don't necessarily have to be a PAR provider with that Medicare Advantage plan unless it's a pure HMO plan.
Okay, so if you're a participant of Medicare, doesn't matter if the Medicare Advantage, if they're in network or out of network, they pay same as Medicare.
They have to process the same as Medicare except in HMO.
So if it says HMO POS,
HMO POS, it doesn't
Have to
matter.
cover it.
They have to
If it
cover
says
it.
the
If it's
POS.
PPO, they have to cover spinal manipulation without prior auth.
now that doesn't mean that they're gonna cover the therapy.
No, it doesn't mean that
Only the Medicare.
what are Medicare guidelines? Medicare pays for spinal manipulation to correct a subluxation. That's the bare minimum that the Medicare Advantage plan has to cover. And FYI guys, watch the fee schedules because they have to cover it based on the Medicare fee schedule. Okay?
So the 98941.
So if they're allowable, let's say, on a Medicare Advantage plan, again, except for the pure HMO plans, that's in a class all by itself. But if it's anything other than a pure HMO plan, if their allowable is $22 and the Medicare allowable is $27.65, they have to pay you based on the Medicare allowable. You need to appeal those.
Okay.
Okay, because what they're trying to do is they're trying to put an allowable based on their commercial plans to a Medicare plan, and the commercials actually have lower allowables than Medicare does.
So we have to follow the Medicare instead of that.
So what are your allowables for 98941 with Anthem Blue Cross in Virginia? 32 something?
No, allowable, it's, the allowable's 4068, right?
Is it 4068?
4068 for Blue Cross Blue Shield.
Okay, for Anthem, right? Okay, so you're actually right in the same, it's pretty much the same.
7977.
Yeah, it's about the same, but in some cases and with some payers and in some states, their commercial allowables are less than the Medicare allowables, all right? And so or they try to impose a Medicaid allowable, even worse, because the patient is dual eligible, so they impose the Medicaid allowable. No, none of that. If it's a pure HMO plan, you've got to follow the plan. But if it's not, then you have to make sure that they're doing their job and that they are billing at least the Medicare allowable, okay? And so make sure that they follow those Medicare guidelines. The other thing that you have to be aware of about the Medicare Advantage plans is that some Medicare Advantage plans don't honor the AT modifier. And again, that may not be a problem out here, but it is a problem in some other states where this is particularly with the Humana plans. The Humana Medicare Advantage plans, if you bill it with an AT modifier, they deny it. And they absolutely, none of the Medicare Advantage plans recognize an ABN. Okay? Now you can have an internal ABN that you use to notify patients in advance of non-covered services, but you would never put a GA modifier on a Medicare Advantage claim, ever. It is not honored, okay? And it'll just cause you, unnecessary denials on your claims if you use a GA modifier. And by the way, for those of you, if you have your codes set up with both AT and GA, get rid of the GA modifier, okay? This is another one of those smart edits where claims were being allowed to pass through with both the AT and GA modifier on the claim, but those smart edits are getting smarter and or dumber, however you may want to put it. But if they have the double modifier, that cancels it out. So basically, you have the AT modifier saying the patient's under active treatment, but then you have the GA modifier saying something has happened with this patient, and we've had either a reduction or a termination of care. And so now the smart edit is going to get confused, and they don't want to see both of those modifiers. It should be either AT or GA. So if you have it defaulting to both modifiers in your software, get rid of that GA modifier and have one code with just the AT and one code with just the GA modifiers, okay? Yeah.
I'm sorry, so since we don't use the GA modifier for Advantage plans, if the visit is a maintenance visit, it just goes in and the diagnosis change or a record, or documentation changes?
Your documentation should change. I don't know. It's one of those things where if you basically what the Medicare Advantage, from what we have been told, okay, on the Medicare Advantage plans that we've talked about, is that if the patient is no longer under active care, you just bill it without the modifier at all. You just take the AT modifier off and you bill it and you get your denial, okay? Typically, the Medicare Advantage plans will deny a non-modified spinal manipulation code to patient responsibility, typically. So just leave the modifier off together, yes?
Are there different types of Medicare cards? So we know there's a Medicare...
Oh yeah, I'm going to go through all of that here in just a little while. I'm going to show you all the different ones.
Okay, also, so with Medicare Advantage, if we submit with the GA, it'll be denied, but not in the same way that it would be denied if we don't?
That's correct.
Okay.
Leave the GA modifier off the Medicare Advantage claims.
Because if you're out of, say for example, if you're out of network and you submit it, you won't know that it's being denied because we're not waiting for them to pay us. So the only person that would know that is the patient.
Yeah, they'll let you know.
So but if they don't let us know, then we would never know.
Yeah,
Until now.
right. Yeah. Yes.
Is Humana still using the 79 modifier opposed to like XS or 59?
You mean the 59 modifier?
Are they using a different modifier than
You're talking about for the therapies?
the therapies? Yeah, is that like 79?
79 is a surgical modifier.
Never mind.
Yeah. So that's not necessarily going to be covered in this particular class because we don't deal with very much physical therapy coding in Medicare for chiropractors anyway. I have a whole physical therapy presentation that I can do for physical therapy coding for physical therapists to Medicare. They have very, very specific rules. So if you're in a medically integrated practice in which you employ a physical therapist, then they need to know what those reporting and coding rules all are, okay? It's very specific, the same way chiropractic is, because they have to certify care and recertify care every 30 days or 10 visits, whichever comes first. So there's a number of different reporting things that need to be done if it's under the physical therapy benefit, but not under the chiropractic, okay? All right, let's talk about a little bit about this deemed provider status. So under Medicare Advantage plans that are PFFS plans, meaning private fee-for-service plans, if an enrollee comes to you and they have a PFFS Medicare Advantage plan, you don't see a lot of them because they are on the higher end of the spectrum, okay? You are classified into either a direct contracting provider, meaning you're in network with that plan, okay, or a deemed contracting provider if you were aware in advance of the PFFS plan's terms and billing terms, right? And you have reasonable access to the plan through an online portal of some kind, and you then become deemed as an in-network provider for that patient, and you have to accept that plan's payment term as if you were in network, okay? Now, you can refuse to treat the Medicare Advantage patient, all right? You can refuse to take that plan, but you have to notify the patient in advance that you are not a participating provider with their plan, and as such, you're not going to bill the Medicare Advantage plan for these services. The patient may then decide to go somewhere else, but you have that right to do that. But if you go ahead and treat the patient and then find out later that this was a PFFS plan, you didn't do your diligence and verification of benefits, and that PFFS plan has really reduced coverage, you have to accept the terms of that coverage under the PFFS plan, okay?
Do you know the difference in the PFFS plans and the regular Medicare Advantage plans?
Sometimes, well, you know how when you verify benefits for commercial plans, like United Healthcare will say, this is a United Healthcare Choice Plus PPO, right? When you verify benefits for Medicare Advantage plans, find out what the plan name is and what the plan type is, okay? So ask that question. If it doesn't say it on the card, if it doesn't say Advantage PPO, Advantage HMO POS, or Advantage PFFS, which a lot of times the card will identify it for you, but if you're not sure, then when you verify coverage, always ask, okay? What kind of an Advantage plan are you dealing with? Because they do behave differently, and there are different appeal rights based on the type of plan and whether you are in or out of network with that plan, okay? And I know it can get very, very confusing, but I think the thing that you have to remember is that all Medicare Advantage plans must follow Medicare guidelines. All Medicare Advantage plans except pure HMO plans, you can be in or out of network and it doesn't matter, okay? So, you know, you don't have to worry about doing a million different credentialing things to get on the Medicare Advantage contracts, except maybe if you want to, you know, add a Medicare Advantage contract to your existing credentialing. But if it's a POS or a PPO plan, it's not really necessary because they're going to pay the same way, all right? Yes, Suzette?
I've been noticing with some of the cards, they're coming in as HMO,
Mm-hmm.
or some are coming in as PPO, or some are coming in as HMO POS.
Uh-huh.
What's the difference in HMO and HMO POS?
POS is an HMO point of service. And so basically what it does is it expands the coverage area to other providers outside of the service area. Yeah.
So if we were not an HMO, let's just use Humana,
Mm-hmm.
we are PPO provider.
Mhm.
So even if we are not an HMO provider for Humana,
Mhm.
we can still process it, and they would still process the spinal adjustment.
Mhm.
Whether or not they paid anything is dependent on their policy,
Right,
whether it was a copay or whatever.
exactly.
Insurance or
Yes,
deductible.
yes.
So they'll still process it. So even if we are out of network for HMO, Humana, in
Mhm.
this case, we can still process it, and we would collect from them as we would for any other.
Now, if it's a straight HMO and there are no benefits, you can't collect from the patient under the straight HMO plan. Under the HMO POS, you can, okay? So you have to know if you're dealing with a straight HMO plan that you are not in network with, because if there are no benefits, you have to notify the patient in advance and then collect, okay? You can notify them in advance that you're not a member of their HMO plan, and if they want, they can try to find, I wouldn't say this, but, if they give you a big fuss about it, you can say, if you go to your Medicare website, you may be able to find an HMO provider. Now, interestingly enough, I have had a couple of situations where patients actually were unable to find an HMO provider in their service area, and then in that case, Medicare awarded the ability for you as a non-contracted provider to see that patient. But it takes the patient getting involved to do something like that. Yes?
If it does come to where, like, say, it is the patient, like you just said, the patient has an HMO, but there's no other providers in that servicing area, can you say they enroll under, like, one of the discount programs like CHUSA or something like that? Could you make them a cash patient if they have a do not submit sign or some form of documentation sign that they're aware and they don't want to go
Yes.
to insurance?
Yes, you can. Not for Medicare B.
Okay.
For spinal manipulation, that is not a CHUSA eligible. For AT Medicare Part B, it's not eligible under CHUSA.
You couldn't treat them under spinal manipulation, but you could treat them.
You could treat them as a CHUSA patient under maintenance. Okay, so once they flip to maintenance and if they choose option 2 on the ABN form, then you could flip them into a CHUSA patient if you want to. Who doesn't know what I'm talking about as far as CHUSA goes? CHUSA is Chiro Health USA. It's a discount medical plan organization, very, very popular within the chiropractic profession, that allows you to create a fee schedule for your cash patients that are discounted deeper than the standard time of service discount, because your standard time of service discounts are about 15% based on the fee. So in other words, if you're really not supposed to be discounting more than around 15% of your fee if you're not under a DMPO, because then that creates a dual fee schedule. So let me ask you this, does anybody know why you actually can do, and I know I'm a little off topic here, but we've got some time, does anybody know why you can do a standard 10 or 15% time of service discount and it not be considered a dual fee schedule? Does anybody know why that is? Yes.
I'm guessing on this, but is it because if you weren't participating, you could charge 115%?
No. It has to do with the codes themselves, okay? And every CPT code has a fee assigned to that CPT code. And within that fee, the way the fee is assigned, okay, the Medicare fee schedule or the Fair Health fee schedule, whatever you're using, that the fee has 3 different components. One is provider expertise and knowledge, okay? The other is malpractice insurance, and then the last part of a fee is practice expense, okay? The way it's broken down is about 80% of your fees represent provider time and expertise, right? 2 to 3% represent, 2 to 5% represent the malpractice insurance the provider needs to have to be able to perform this service on the patient. And then the remaining 15% is practice expense. So what are you eliminating when you have a patient paying at time of service? Practice expense. You're not sending a statement. You're not billing the insurance. You're not paying a staff person to file the claims. You're not paying a billing person to file or a billing company to file those claims. So by eliminating that piece of the RVU, which is the relative value unit of that service, you can legally discount that. But it's only up to 15%. So if you want your discounts to be deeper than that, you need to sign up with some type of a DMPO, Discount Medical Plan Organization, of which CHUSA is probably the most well-known and most popular. They do a lot for the profession. So I know the UVCA endorses them. There are others out there, but basically what happens is you can then take your fee schedule and you can create deeper discounts that are written into a contract, into a policy. So the same way you have a contracted plan like Anthem, where you agree to take this fee as payment in full, CHUSA does the same thing for you with your cash fees, all right? So that's the beauty of a discount medical plan organization, is that it allows you to create a fee schedule, a true fee schedule for your cash patients, and you can set essentially whatever fees you want. And CHUSA is very good about, when you sign up with them, they will analyze your fee schedule with you and they'll tell you if your discounts are too deep or not, and they have a very strong compliance division that will help you with that. So little plug for CHUSA there, but they're a wonderful organization. That's another, Chrissy Hudson is going to be on the cruise too, so we're going to be doing a big CHUSA segment of our conference. So anyway, kind of going back to the deemed provider status, if I may, get back in gear here. A provider is considered to be aware in advance of the enrollment notice if it was obtained from their insurance card. So if it shows that the insurance card is a PFFS plan, you're kind of hosed. You're not going to be able to tell the insurance company, oh, I didn't know that this was a PFFS plan, right? If they're going to ask you, well, did you get a copy of the insurance card? Well, it's right there on the insurance card. So now you knew, so now you have to notify in advance whether or not you want to take that PFFS plan and bill for it. The carrier, there may be a plan website is another one where they'll argue and say, look, you have access to Availity, you have access to our payer site, don't you verify benefits in the beginning? And if you did, you would have seen that this is a PFFS plan. And so typically it's hard to get out of that deemed provider status, so it's really important to make sure that you are following the correct rules for deeming. So it's basically saying that this is an example, and this actually comes directly from Medicare, says an enrollee walks into a physician office for the first time, advises the physician that he or she is a member of the plan. Who does that? What patient advises you what kind of plan they have? It's like, give me a break. And presents his or her plan enrollment card. So maybe they don't tell you, but they give you the card, right? And the logic of the payer is, and Medicare is, since the provider had the opportunity to call the plan on the enrollee card, the provider is considered deemed contracting as soon as he or she provides services, even though the provider did not actually check the terms and conditions of payment, okay? So it's important for you to just make sure, again, what I think, if I can get anything through everybody's heads when it comes to Medicare Advantage, it's verify coverage, okay? Know what the terms of these plans are, okay? Create a spreadsheet that's maybe a little cheat sheet of the different plans and what the plan's terms are, and you'll be in a lot better shape. What is the timely filing for Medicare Part B?
365.
What is the Medicare timely filing for Medicare Advantage?
Hopefully the same thing.
Nope. 365. If it's a Medicare plan, United Healthcare cannot tell you you have a 90-day timely filing on a United Healthcare Medicare Advantage plan. 365 days, the same as Medicare, okay? So that's definitely something that you need to be aware of. Medicare processing time. Medicare is like clockwork. Medicare Part B, if you submit a clean claim and Medicare accepts it for adjudication, you will get paid in 14 days. Unless they pull the claim for a prepayment audit, okay, you will get paid in 14 days. And so you can expect your Medicare payments like clockwork. Now, Medicare Advantage, up to 30 days for Medicare Advantage, okay? Any questions on this part? How are we doing on time? Yes,
That would be for PAR, so if it's non-PAR, like how long does it take
14 days.
for the patient to get reimbursed?
Yep.
That's it?
14 days, if it's a clean claim, yes. Okay, see how we're doing on time here. 2:12. Okay, we're doing good. We'll take a break after this little segment. So let's talk about coordinating benefits, because I think it's important for us to have a really good, clear understanding of, especially now, this is good, this is really where, you know, your front desk CAs are going to shine, because who ends up putting all the insurance into the computer system? It's usually the front desk CA. So if you don't have a front desk CA here, this is something you need to bring home to them to make sure that they understand how to correctly profile Medicare and Medicare Advantage patients in your software system so that you don't have delays in claim processing, okay? So every Medicare patient, whether they are Medicare Advantage or not, receives this card, all right? We call it the red, white, and blue card, and that's what we're going to refer to throughout the presentation today. So the red, white, and blue card is the health insurance card that they get from CMS, from the Department of Health and Human Services, that shows when their Medicare coverage began, all right? Honestly, that's all it does, okay, is it shows you when coverage began and whether the patient is eligible for Part A and Part B. So sometimes you may get this card and it may only say Part A. And if it does, it means they do not have Part B, they do not have a Medicare Advantage plan. They cannot get a Medicare Advantage plan unless they've enrolled in Part B, okay? So you have to verify when you get a Medicare card, verify, just glance at it, make sure it says Part A and Part B on the card. Very important. This is an example of a Medicare supplemental plan, also known as a Medigap plan. This plan is purchased, this type of plan is purchased when a patient has original Medicare, which is Medicare Part B, all right? These Medigap plans are usually identified by a letter, okay, A through L, I believe. And they can be administered by, AARP is probably one of the most popular ones of the Medigap plans. But the plan letter actually indicates to you what the patient's cost share is or is not going to be for Medicare covered services, okay? It determines that level of payment. Now, one of the things to remember about Medigap plans is think about the word gap. It is designed to gap the coverage. Remember how we said early on this morning that Medicare Part B, original Medicare, has a $200 coming up in 2024, $240 deductible, and then they pay 80% of covered services. And 20% is the patient's responsibility, and there are no out-of-pocket maximums. So there's never a point in time with a Medicare patient where after they've paid so many of those 20% coinsurances that Medicare is going to start covering 100%. It doesn't happen in Medicare Part B. Medigap plans gap that 20% coverage. So essentially, they will take what is left after Medicare has paid the 20% and then pay anywhere from 50 to 100% of that 20%. Okay? So whatever is left, that's the gap. But if Medicare does not pay for it, or it's not covered by Medicare, the Medigap will not cover it either. Okay? Very, very simple, very, very straightforward. All right? So this is a chart that is actually in the Medicare and You booklet that the Medicare patients get. So what it shows is by the plan letter, it's A through N, sorry. By the plan letter, it will tell you what percentage of the coinsurance does it cover, all right? So essentially, plan A through plan G, and then again plan M and plan N cover 100% of the 20%. Does that make sense to everybody? Plan K covers 50% of the 20%. So that means the patient is still going to have a balance at the end of the primary and secondary payment. It's going to be tiny, but they'll have a balance. You know, they may have a $4 or $5 balance left on their account. So you have to be sure that you're collecting appropriately based on the plan letter that you see on their Medigap card. There are only 2 plans that cover the Part B deductible, Plan C and Plan F. Now, Plan C and Plan F are no longer sold to new Medicare beneficiaries. Those plans are grandfathered in, and once every Plan C and Plan F patient dies, you will no longer have coverage for the Medicare Part B deductible. So come January, it's important for you to look at that Medigap card to see what the plan letter is, because if it's not a C or an F, you're going to have to collect that $240 deductible on the spinal manipulation if the patient is coming to you first, right? I mean, you know, the patient's going to meet their $240 deductible in no time at all, but in January, it's January and February is when it's most likely that your services will apply to their Medicare Part B deductible. So now you can verify that by going online. I'm going to show you that later on today is how to go online and check to see if they've met their Part B deductible or not. But those are the only 2 Medigap plans that cover the Part B deductible, okay? C and yes, C and F.
And C and F, you're going to have to collect.
You're going to have to collect the deductible, yes. Okay, this will save you guys a lot of heartache come January. So, yes.
What's the difference between coinsurance and copayment?
Okay, so a copayment is a flat fee, all right? There are some very, it's like minuscule plans that fall under it's a Medicare shared savings program. We're never going to see that in chiropractic, at least not yet. But in some medical practices that participate in the Medicare shared savings program, instead of the patient having a 20% coinsurance, they actually have a copay, all right, and that the patient pays up front. But I wouldn't worry about that. But a copay is just a flat rate. No matter how much service is done, the patient pays the same amount if they've gotten just the spinal adjustment or if they got adjustment therapies and exams and everything. But it really doesn't apply to chiropractic because why? The only thing that's covered is to correct a subluxation, period. Okay, it's very, very limited coverage. So this will actually, it's a good idea to go into your 2024, it's the best chart really, because it's one that you can laminate and you can actually show it to the patients. So, and if it is a true Medigap plan and you can see on the card that it's a Medigap plan, you don't have to call and verify that. It is what it is. They're all the same, okay? So it doesn't matter if the Plan F is from United Healthcare or from Centene or Kaiser or whatever. If it's a Medigap plan, they're going to have the same exact terms, no matter who that is, okay? So make sure that, and the other thing to remember about the Medicare supplemental plans is that these are what are known as crossover plans, meaning you do not have to bill these. Medicare will automatically forward their determination of the primary claim to the supplemental Medigap, and Medigap will automatically process it. The only thing you'll have to do is profile the insurance in your software so when the check comes in, you have a plan to apply it against, right? Okay. Any questions on Medigap? Sometimes you have these true secondary plans. These are usually union retirement plans. They may provide expanded coverage, such as payment for exams, x-rays, therapies. If the insurance card does not clearly indicate that it is a Medigap plan, I would recommend verifying coverage on that particular plan. And again, the questions you would ask is, do you strictly follow Medicare guidelines, or is there expanded coverage beyond what Medicare covers? Medicare, and I don't assume that these customer service reps know anything, so I explain it to them. I say Medicare only covers these 3 spinal manipulation codes, but some plans will cover additional services. Is this one of those plans? And then they'll let you know, okay? And so anyway, this is more of a true secondary type of plan. This is how you would identify possibly a Medicare Advantage plan. So most of the time it will say something like Medicare Advantage, Medicare Replacement, MA, PPO. There's a lot of different wordings that you may see on the card, but most of them do give you a pretty clear picture that you are dealing with a Medicare Advantage plan. It's just a matter of understanding and reading the card. So let's say you're a front desk CA and you did not query the patient prior to them coming in for services, okay? And they present this card to you. What would you have to do with that patient when they came in? Have a seat. Verify if you're on their HMO plan, and if you're not, notify them. If you do not notify them and you bill it and it's denied, then you have to eat that. Okay? So stop everything. And that is one of the, over the years, telephone scripts for new patients have changed quite a bit. I remember years ago when I was a practice coach, we were like, don't ever talk insurance to your patients over the phone. But now with the No Surprises Act, with these Medicare Advantage plans, you almost have to. You almost have to do an insurance questionnaire, kind of a little query with the patient over the phone, okay? I still recommend that you schedule the patient and then you ask them, by the way, do you have any insurance you'd like us to check on for you, all right? And then if they say, oh yes, then say, all right, do you have your card, your insurance card? Now, can you tell me on the insurance card, do you see anything that says Medicare Advantage? Does it say Medicare Supplement? Is there a number? Is there a letter? Kind of query them a little bit. And if they say, oh, it says Medicare Advantage HMO, you're like, okay, great, thanks for letting me know. Let me get this information from you. I'm going to call your plan and see if we are in network with your plan. and see if there are any out-of-network benefits, all right? And the patient will definitely appreciate that, right? Instead of coming in, have a seat, wait, good luck trying to get through to the plan to find out, what the terms are. But it's very, very important, if the bottom line with these patients is if you treat them, you have to abide by the plan terms. So if it's an HMO, and if the HMO says no benefits, it's no benefits. Now again, if it's HMO POS, it's a different situation. So make sure that your front desk staff is well versed on looking and reading these insurance cards. They may not know a lot about insurance, but they do need to know how to read these cards. Yes?
We asked them over the phone to take a picture of their card and their driver's license and text it to us. And we're allowed to call and get their benefits, are we?
Yes, you can. You can call and get benefits. There are some HIPAA things, but, texting, those cards over to you yeah. So one of the things that you might want to do is if you have some kind of a companion program that's like a portal where they could scan it in ahead of time, that's better. Where you're safe is if the patient volunteered to send you that information, then it's not a breach because they gave you voluntarily that information. What I would do is if you want to use a telephone, get a burner phone for the practice that's only used, and it's not on anybody's personal cell phone. So don't give them your front desk CA's cell phone number to where they take a picture and send it to your front desk CA. Spend $25 a month to have a burner phone that's used just for clinic business, all right, and it's not used for anything else, and then it's locked away at the end of the day because then it's secure, all right? And remember, even with that type of a burner phone, you can't be outgoing messages to patients or to your billing company or whatever that contains PHI without the patient's express written consent, okay? Yeah. Any other questions on that? Yeah.
I do. Everybody else might know this, but Medicare Advantage is in tiny letters in the corner on the bottom, practically off the page. An elderly person may have difficulty finding that. Are there other clues as we're querying the patient? I see Medicare RX, CMS, but a patient isn't gonna, how could we elicit a good response?
I know, it's hard. Because unfortunately the Medicare patient, like it was mentioned earlier, they may think that the red, white, and blue card is their Medicare card and that this is a supplement, right? And if they're having a hard time reading the card, then you're kind of going to have to wait until they come in to verify that. Again, the idea of them taking a picture of it and then sending it to you, in a picture. Unfortunately, ChiroTouch and some of these other chiropractic programs have never bothered to set up a patient portal. Okay, there are companion programs, companion apps that create patient portals. There's one called Inbox Health, which is a great one. That basically creates a portal for you to be able to securely move documents. But again, an elderly patient,
70-year-olds can't take pictures and texting anymore.
it's going to be, I don't know, my mom is 86 and she's like a beast when it comes to FaceTime and pictures and Facebook and all of that. She's crazy.
On some of the commercial plans, the beginning letters gives you a hint of like the company that they work for, you know what I'm saying?
Well, yeah, on the commercial plans they do, but
so
sometimes...
there's no identifier on the Advantage plans at all.
There actually are. So you can go to Blue Cross Blue Shield and you can ask them for an alpha prefix list, a list of the Blue Cross alpha prefixes in your area. And you may be able to get it through Availity. I don't know for sure, but I know you can call and ask for a list of the alpha prefixes, and it will tell you what kind of plans those alpha prefixes are, whether they're employer-sponsored plans, which fall under ERISA law, they're Medicare, they're your individual marketplace plans or Medicare Advantage plans. And so for Blue Cross, yes, you can do that. Not so much for United Healthcare, Aetna, Cigna, Humana. They don't really differentiate or distinguish. But Blue Cross plans, you can identify your Advantage in your marketplace plans by the alpha prefix. You know, same thing with ASH, by the way. You know, you should be able to call ASH and get a list of the Blue Cross alpha prefixes that are administered through ASH, if you take ASH, okay? So, if a patient has a Medicare Advantage plan and they bring you the two cards, let's say they bring you that Medicare Advantage card, and then I'll answer your question in a second. They bring you the Medicare Advantage card, then they bring you the red, white, and blue card. This red, white, and blue card is what I call a set aside. You set it aside, scan it, put it in their EMR, but you do not put it into the profile for billing because it doesn't get billed, okay? Yes, what was your question?
So is this the only card that we use if they only have the original Medicare Part B?
That and maybe their Medigap.
Okay, so there is no other card. So if they bring a card that says, for example, Humana on it, and they're like, this is my Medicare card, and there's nothing else on it other than Humana.
And they tell you that it's Medicare Advantage, I would take their word for
I'm
it.
saying they say it's Medicare.
No.
No, it would not be, right?
Well, it could be a Medicare Advantage
That's
plan.
the only thing it could be.
It could be a Medicare Advantage plan. It could, and again, you have to look at the card because if it says Humana Medicare Supplement Plan F,
No, I'm saying it says nothing.
oh,
Humana.
it says nothing but Humana, then you need to check.
Then we need to check.
Yeah.
But it cannot be an original Medicare because original Medicare only has one card. Which
Yep.
Is red, white, and
That's
blue.
very right.
That one, yeah. Yes. Okay, so you just keep a copy on file. So this basically is not profiled within the practice management software system. Okay, what comes first, the chicken or the egg, right? Medicare is a secondary payer. In some cases, Medicare may not be primary, and we're actually seeing more and more of this as our 65 and older population are still working. Okay, so they're still employed gainfully in full-time jobs, but now they become Medicare eligible. And so they go ahead and elect to get Medicare, right? But does Medicare become the primary or is Medicare the secondary? And the answer to that is based on if they are working full-time and whether the employer and how many employees the employer has. So the rule is if the patient is 65 or older and they have group health coverage based on themselves or their spouse may be working, okay? So we've kind of had this situation in my household. You know, I'm not 65 yet, right? My husband is 67, so I have insurance, he has insurance, but we have fewer than 20 employees, right? Then the Medicare pays first, okay? So if you're 65 or older and you have group health and you or your spouse work for a company that has 20 or more employees, the group health plan pays first, Medicare pays second.
So how do you know how many their employee has?
You have to ask them. Yeah, who do you work for? You know, if they say, I work for, the florist shop down the street, most likely Medicare. And the other thing is that you can check it online, okay? And I'll show you that in a second, because when you go to the Medicare portal and you check online, there's a tab called MSP, that means Medicare Secondary Payer. If you click on, after you key in the patient's information, you'll be able to find out if the patient has Medicare B or Medicare Advantage. You'll be able to find out if Medicare is primary or secondary, and you'll be able to find out if they have B, whether they've met their deductible or not, okay? And it's a very, very quick online query that you can do to find out all of this information.
Where did you say to find that?
And your e-services portal through Palmetto. Yeah.
And it's called, what's the abbreviation for it?
MSP, Medicare as secondary payer.
What if
Okay?
the patient says, I want you to send to Medicare?
What do you mean?
Like if they're in this position,
Yeah.
but they're like, no, I want you to send it through Medicare.
You say you can't.
Okay.
Yeah, you say that this is the rule, and you can, if you have a copy of the Medicare and you document, you say this is what Medicare gives you every year, and as you can see, if you or your spouse work for a company that has over 20 employees, we have to bill the group health plan first and Medicare second, okay? Or neither one of them is going to pay.
Our responsibility is to bill Medicare if the patient asks to bill Medicare. Our responsibility isn't to bill according to the patient's instructions.
You have to bill Medicare for covered services, whether the patient asks for it or not.
The patient is demanding that we submit this way and
No.
submit that way.
No.
They can apply for the job as the office manager.
That's right. They can apply for the job as the office manager. No, I mean, if you want to educate them, you can use the documents that Medicare gives them. This is the same document that I would give a patient, that is very, very clear, and then give them the telephone number to Medicare customer service if they have a problem with it. And if they want to go and complain to Medicare that we're not billing it the right way, then by all means, and don't let your fanny, don't let the door hit your fanny on the way out. You know what I mean? But yeah, so, the rules are the rules. And a lot of times this is how I have always approached Medicare patients, is that it's Medicare. There are very specific rules on the way we have to do things, okay? And so in your best interest and to get you paid as quickly as possible, we have to do it this way. And if they say, no, I don't want, I just did 10,000 steps, guys. I just felt my phone vibrate. So anyway, if the patient wants it a different way, it can't happen. It's just not the way it's done. It's not, it's not going to work, right? Now, if the patient is under 65, meaning they have Social Security disability, the employer number changes, the employee number changes. So the employer would have to have 100 or more employees for the group health plan to pay first, okay? Medicare would only be secondary if it's a very large company like Boeing or, any Amazon or Walmart or something like that. Then the group health plan would pay first. But if the patient is on Social Security disability and they qualify for Medicare, then the question is who does either your parents work for, if they're covered under their parents as a disabled individual, and sometimes even adult people with disability are covered under their parents because their parents are their legal guardians because of their disability. So you have to make sure you understand the criteria for when Medicare would be considered secondary. And it would be secondary if they're over 65, they're still gainfully employed by an employer that has over 20 employees, Medicare is secondary. If they're under 65 on disability and the employer has over 100 employees, Medicare is secondary. Otherwise, Medicare is primary, okay? And the employer-sponsored plan becomes a true secondary plan, okay, and not a Medigap plan. So in that case, maybe they have expanded coverage if they're still working, okay? Medicare still may be primary, but the secondary is actually a true secondary that could have additional coverage. Okay? Any questions on that?
If Medicare is a true secondary,
No, not Medicare, but
no, if Medicare is a secondary.
I only cover spinal manipulation.
That was my question.
Yes. Yeah, the coverage is still the same. Doesn't change, right? So, let's say the patient has an employer-sponsored plan that's primary. Here's the trick. You can't bill an AT modifier on the primary, right? right? And you're not really supposed to be using the M99 codes. So it does make it a little tricky. So you have to kind of manipulate the claim a little bit in order to, you have to add that AT modifier, to that employer's, to Medicare when the secondary, and it's not an auto crossover, so you have to manually bill Medicare as a secondary payer, all right? Okay, so little exercise. So the patient brings you these two cards, all right? This is a red, white, and blue Medicare and an AARP Medicare Plan F. Which card is profiled as the primary?
Red, white, and blue.
Red, white, and blue, and then AARP is profiled as the secondary plan. That's correct. All right, here's the next one. This is a Medicare and a true secondary. How's it profiled?
Say that again?
Medicare and a true secondary. Red, white, and blue is primary, and then the true secondary is profiled as the secondary. Okay? This is not a Medicare Advantage plan. This is a true secondary plan. And the patient doesn't have Medicare Advantage. They have Medicare, and then they have the secondary, and it is determined that this employer-sponsored plan has less than 20 employees. So now we have a true secondary plan. Medicare is billed, and then the secondary is billed, okay? Always check benefits on a plan that does not clearly state that it is either, whether it's Medicare Advantage or if it is a true secondary or a Medigap. If you can't tell by the card, then you need to check on that. What about this one? This is a Medicare, Medicaid, Cover Virginia Optima Health card. So what is primary and what is secondary?
Red, white, and blue is primary.
Red, white, and blue is primary. Optima Health as Medicaid is secondary. This is a dual eligible patient. Okay. All right, how about this one? They bring you your red, white, and blue card, and then they bring you that Essential Advantage HMO. Which is primary and which is secondary?
The HMO is primary.
HMO takes place of
Yeah.
both.
Okay, so what do you do with this one?
File it.
Nothing. You file it. Perfect, guys. Awesome. So that becomes primary, right? It replaces Medicare Part B. That one you don't even profile. You make a copy of it, put it in their chart, and you're done with it. You don't have to do anything with it as far as submitting that to Medicare, okay? The patient brings you this. Now they are still working, and there are 60 employees at RLI. Which one is primary and which one is secondary?
Group is primary,
Why?
because they have 60 employees.
They have more than 20 employees. So they have, so RLI becomes the primary and Medicare becomes the secondary. Woo, auto case. What happens when a Medicare patient is involved in a car accident?
You have to send it to both. Primary.
So who's primary and who's secondary? Auto is primary, Medicare becomes a secondary payer. The Medicare patient is required to notify Medicare that they've been involved in a car accident, okay? Medicare sends these claims to what's called a subrogation unit, all right? And the Medicare patient actually has the right to request advance payment from Medicare, all right? Now, most patients don't do that unless they've been involved in having some like really serious health issues, like they're going to have a major surgery as a result of the accident or something like that. But Medicare can make what are called conditional payments to the patient to help them cover their expenses, and then what they do is after they've paid in the settlement, then they recoup that money from the auto carrier. It's not common. We don't really see it very commonly in the chiropractic world, but I do see it in the medical world quite a bit. But in this case, the auto insurance is primary, Medicare is secondary. Have you ever had a situation where you've billed Medicare and they've denied the claim stating that this is covered by their auto carrier? Okay, and then you talk to the patient and the patient says, I had an accident 5 years ago, right? So what happens is when Medicare is secondary due to an auto accident, not only does the patient have to inform Medicare when they have the accident, but also when the claim is settled. So they're supposed to go in and tell Medicare, my claim is settled, we won't be billing the accident anymore. What happens sometimes is the patient was in an accident 3, 4, 5 years ago. They went to see a chiropractor. The chiropractor billed a certain diagnosis code through the auto carrier that was then sent to Medicare. Medicare has that on file, all right? And when that diagnosis code hits Medicare again, they still think that it's part of the accident. So that's what happens. And so the patient has to do that. And I've actually done, probably in my career, maybe a half a dozen calls, because the patients don't understand it, where we've done a 3-way call with the patient, with Medicare, and with myself, so that the Medicare rep could explain to the patient what they needed to do, you know, to get that off the record, because it can be a real, like, like you feel like you're on a hamster wheel going back and forth with Medicare about that. And Medicare cannot do anything until the patient notifies them that the accident is over and that the claim is no longer being pursued anymore and the claim is closed. Yes?
What can we do, like, I've had just recently, a patient who was involved in a motor vehicle accident, only wants us to file with Medicare. Let's just say on a side note, he's a retired chiropractor
Mm-hmm.
who knows everything about Medicare, not Virginia.
Mm-hmm.
Anyway, so he only wants to file with Medicare.
Mm-hmm.
So, of course, we're filing it or denying it, and he is just shocked, but, anyway, when we file to Medicare and they deny it, we don't have to, we can show them it's a process, but not doing write-offs because we don't have to.
Mm-hmm.
What if you have an attorney that says you have to file with their health insurance and we state it's Medicare? Because lots of times the attorney wants the write-offs, you know, they want us to take the write-offs.
So the patient has Medicare and health insurance?
No, Medicare and an auto insurance.
Okay, okay. Well, you know, you basically, again, the rules are the rules are the rules. And what you do is you tell the attorney, we're going to file it, but we're not going to file a false claim, all right? And when we file it, we're going to indicate that this was an auto accident, and Medicare is going to deny it because they are not the primary payer.
Now, is this strictly chiropractic coverage, or is it across the board?
Across the board.
People come in and say, well, I saw my primary care for this, and they just filed it to Medicare.
Across the board, yeah. The problem is what happens is that some of the medical providers will file it and they won't mark that it was due to an auto accident in box 10, I think, right? So where it says, is this a result of an accident, yes or no, they just mark it no, so Medicare doesn't even know that it was due to an accident. But the second you mark yes that it was due to an auto accident, Medicare is going to deny it. So you can do anything the attorney wants, but you can tell them, we're going to be compliant. We have to notify Medicare that this was due to an accident, and the second Medicare sees that, they're going to deny it, right?
It's just odd that they would even ask us to do it.
Well, because they want to take the write-off. They want the provider to take the write-off so that they can reduce the amount of the settlement. That's basically the reason why the attorneys do that, okay? So, all right.
Workers' comp, PI, auto, all of them.
So what if the patient brings you this mess? So they bring you the red, white, and blue Medicare card, they bring you their Medicaid card, and then they bring you their Essential Advantage HMO Medicare replacement card. How do you profile that?
The HMO would be primary, Medicare would be secondary, and you just put that one for the record.
That's it, it's just the Advantage plan, and do you bill Medicaid still?
It's a dual eligible.
Yeah.
So the only time that the Advantage plans have a secondary is with a dual eligible patient. So in this case, the Medicare Advantage is billed first, the Medicaid is billed second because they're dual eligible, and you don't do anything with that Medicare card, right? This is the only time if you have an Advantage plan that you're going to bill a secondary is when there is a Medicaid plan involved, okay?
And then if they're not a Medicaid participating provider, do you still have to bill the Medicaid portion?
Not if it's, no, not if you made the correct notifications, no, you don't.
But could you bill the patient according to the primary EOB, even though they have Medicaid?
Now, remember, you're going to have to bill the Medicaid plan for what services? Spinal manipulations for active treatment. Okay. Even if you're not a provider, dual eligible, you're going to have to bill the Medicaid plan, okay? Medicaid's going to deny it. You cannot balance bill the patient for the spinal manipulation. For any other services, you can notify the Medicaid patient in advance of care that it's not covered, Medicare doesn't cover it, their Medicaid plan doesn't cover it, they're going to have to pay out of their pocket, all right? But you are obligated under dual eligible rules to bill the secondary or the Medicaid plan for services that were covered by Medicare or Medicare Advantage, okay? So with that said, which brings up a great question, so let's say that this is an HMO plan or a Medicare Advantage plan that has expanded coverage, all right? And they pay for exams, and they pay for x-rays, and they pay for all the extra services. If you bill that Medicare Advantage and you get payment for those services and the patient has Medicaid, then you have to bill Medicaid for those services that got approved and paid. Medicaid will deny them, and then you can't balance bill the patient for the rest of it.
Regardless of Medicaid participation?
Regardless of Medicaid participation. It does not matter if you are in Medicaid or not. You may not balance bill dual eligible patients for any services that would be covered under their plan, whether it's Medicare or by Medicare. Okay, does that make sense?
So when you send it in, you just don't click accept assignment from Medicare, Medicaid, I mean.
No, you would still have to. You can. I don't think it matters either way. I don't think it matters either way whether you accept assignment or not. It's not covered because it's chiropractic, right? It has nothing to do with in or out of network. It has to do with it's not covered under chiropractic. Yeah.
So we file it, but we know they're not going to cover it.
Yes.
Okay.
Yes. And most of the time, you're not going to have to file the Medicaid because it's a crossover. Medicaid automatically, when it's a Medicaid plan, Medicare will automatically forward that claim information over to the Medicaid plan.
That includes the Medicare Advantage, they
Yes.
cross over.
Yes,
So technically, if it's a crossover, you don't have to bill.
That's right.
It's already billed.
it's already being billed. Yeah,
Okay.
okay?
So not two separate filings.
No. Not if it's Medicare and if it's a dual eligible patient, if it's either Medicare B or Medicare Advantage, file first, right? They cross over to the Medicaid plan, okay?
Right, question. So let's say you have a child, they have group insurance under the father, but they have Medicaid under the mother.
Okay,
So the coverage, that's not a crossover.
no,
So you would have to bill the Medicaid
yeah,
separately.
that's different because we're dealing with commercial plans. Medicare, as far as I know, is the only payer that does an auto crossover from primary to secondary. I hope I'm not confusing you guys too much.